Up next, we have an esteemed speaker, Dr. Amarnath Bhide from the UK. He will be sharing his global insights on the topic pre-eclampsia, antepartum management, and when to deliver. He is a consultant in fetal medicine and obstetrics at the St. George Hospital in London. He is a lead for the Day Assessment Unit and honorary reader at St. George University of London, and the co-director of the MFM subspecialty program. Sir is also a deputy chief editor for ACTA Obstetricia Gynecologia Sandy Navikia and the member of the editorial board for two other journals. Welcome aboard, sir.
Thank you. Thank you very much. Thank you for the kind words. First of all, before I start, want to thank Dr. Jayakrishnan for asking me to visit this beautiful city of Thiruvananthapuram. I'm very happy to be here and to be speaking with you about preeclampsia. Now, this is an old topic, and we know a lot about preeclampsia. We've seen cases, all of us have. But I want to show you this picture to you. This is a picture of the foyer of the Chicago Lying-in Hospital. This was taken somewhere in around 1951 or 1950, 1960. And you see there are 4 pillars there, and on top of each pillar, you can see some faces. Now, these faces are well-known individuals who have contributed to the field of obstetrics and gynecology. You can see that this pillar is vacant. And that is reserved for the person who will develop a cure for preeclampsia. But this is still vacant because we don't know what the cure is. I mean, we do know, but we don't know what actually causes preeclampsia. So there are a lot of things about preeclampsia that we know. We know it is a disease of pregnancy. We know it can lead to maternal and fetal complications. And we also know that it is cured by delivery. So in a way, we know what cures preeclampsia. But although we know that, that is not the answer. If somebody does develop preeclampsia, it doesn't mean that we deliver all of them, because there is a problem, because we can't deliver preterm preeclampsia. There's a problem. We know that preeclampsia is a multi-system disease, and we know it is caused by placenta. Placenta is out, and preeclampsia gets over, it gets cured. Even if there's no fetus, preeclampsia can happen. But if there's no placenta, it can't. We know that it is related to placenta. Now, there are 2 pathological features of preeclampsia that are vital or seminal, and that is vasospasm and capillary leak. And capillary leak happens because of dysfunction of the endothelium. And these 2 features, if we remember these 2, we can explain everything about preeclampsia, why everything happens. It can affect the kidneys, it can affect the liver, hematological system, brain and the placenta, and in some cases, the heart. So all these can be explained on the basis of these 2 features, vasospasm and capillary leak. Now, I want to remind everybody about the definition of preeclampsia. And this definition of preeclampsia has undergone a change recently. We have been taught in medical school that anybody in pregnancy develops high blood pressure and proteinuria is preeclampsia. And for diagnosis of preeclampsia, we need both of these. We need high blood pressure and we need proteinuria. But come to think of it, why are we so fixated on proteinuria? And what is the proteinuria a sign of? Proteinuria is a sign of capillary leak. If the endothelium becomes leaky, it allows protein to be filtered in the urine, and that's why we get proteinuria. And that's something that is easy to check, doesn't require a complicated technology, and it can be also done in outpatient setting, and that's why it was a vital feature of developing or diagnosing preeclampsia. But of late, we have realized that uteroplacental insufficiency is also a sign of endothelial dysfunction and vasospasm. So if the placenta doesn't work properly and the baby is affected, then even if proteinuria is not present, it is not logical not to call it preeclampsia. And that's been a change in the definition or diagnostic criteria for preeclampsia. Rest all hasn't changed. So either we should have proteinuria or we should have evidence of other endothelial or end organ dysfunction, like kidney injury, like liver dysfunction, like neurological complications, like hematological complications, and all these can be explained by the two features that I mentioned to you. Now, thinking about the effects of preeclampsia, we know that it can lead to some maternal effects, and that's cerebral edema can happen because, again, leakage of fluid in the extravascular spaces of the brain that leads to swelling of the brain. Vasospasm leads to hypertension and renal failure because less blood is getting to the kidneys. Endothelial injury can lead to activation of platelets, so that leads to low platelets and consumption of coagulation factors, so DIC can happen. Albumin leakage can lead to proteinuria and can lead to swelling in the lungs, so pulmonary edema can happen because of that. And there are some fetal effects that we should be aware of, and we know about that, and that is growth restriction. The baby can't grow properly because the placenta doesn't work, and the function of the placenta is to exchange. The placenta isn't able to do that, so it does lead to growth restriction. Prematurity is largely because of iatrogenicity. If somebody has got developed severe preeclampsia, you will deliver them early, right? So largely it is because of prematurity, but there's also a higher chance of women going into labor naturally, preterm labor naturally. And sometimes we forget this association, but that is true. So nature is trying to sort things out. Somebody develops preeclampsia, they are more likely to go into preterm labor on their own. There is a higher chance of placental abruption because it's like the placental roots, the villi, they aren't embedded deep enough. So they can get uprooted quite easily. So abruption can happen, and sometimes fetal death can happen, and we know that. So all these are complications, and all of them can, as we have seen, can be explained on the basis of vasospasm and endothelial injury. Now, how do we manage antepartum preeclampsia? So it's generally accepted that hospitalization is recommended for monitoring, and that monitoring is at least twice daily blood pressure measurements are necessary. But that's not always true. If somebody has got well-controlled preeclampsia, it's not wrong to manage them as outpatients. And in my hospital where I work, we very rarely admit patients just because they have preeclampsia. For us, if the woman requires or the preeclampsia becomes so severe that she needs admission to the hospital, then she should be delivered. So the only reason why women get admitted in my hospital is because they are going to be delivered. Unless all other women, we can manage them as outpatient visits, because women are happy to come to the hospitals maybe 2 or 3 times a week. That's not something that women don't want to do. What they don't want to do is to come in the hospital and stay staring at the ceiling doing nothing. So that's what they don't like. What about delivery? We are on the lookout for symptoms of severe preeclampsia, and I need not tell this august audience what these symptoms are. And also, we are looking at some blood markers. So we are looking at PT bloods, and the battery of tests that we order, they are often called PT bloods, and we are basically looking for full blood count, and particularly platelet count, and we're looking for liver function tests, so elevated liver enzymes. Unless the platelet count is low, we don't bother doing coagulation screen because it's not going to be abnormal. When the platelets become abnormal, only then coagulation screen is important. Frequency of doing platelet PT bloods depends on the severity of the disease. Now, there have been attempts to figure out prediction of adverse maternal outcomes. So this one particular paper was published some time back now, and that is trying to predict adverse maternal outcomes. And the predictors for adverse maternal outcomes are gestational age. The earlier it develops, the higher is the chance that problems will happen. Presence of chest pain or dyspnea. If somebody is struggling to breathe, it's a higher chance that they will develop problems. Oxygen saturation, low oxygen saturation is obviously a problem for the patients. Low platelet count, higher chance of developing problems, and elevated creatinine or ALT. Again, problems occurring. So you might ask me, what new information have you told me? I know all this. So what does it matter? Why should we be bothered? Why should I read about this paper? The importance is not only that what leads to adverse outcomes. This particular table that I've put in here is quite interesting to look at. And if you see, that column on the left-hand side is the predicted probability of developing complications. And we say predicted probability, we're talking of less than 1 to 2%. So this is in terms of 0.024 is 2.4%. Okay, so that's how it is. It is here. That is the predicted probability from the model. And if we see the observed probability, it's exactly the same, 1 to 2%. On the other hand, if you go right at the bottom, the predicted probability is between 20 and 30 or 20-30%. What we observe here, exactly the same. The observed probability of developing severe maternal problems is 30 to 50%. That is what is important about this model. It just doesn't tell you what the factors are. It tells you how much likely it is, how much more likely it is. And this model is a complicated one. It requires mathematics, but we don't need to be bothered about. The model is available online. So if you look for it, PS prediction model, it is available there. You put in your values and you will get the predicted probability of development of complications. So that is what is new about this. There's another such model available called the PrEP model. That's also available. So there are models that people have developed for predicting the probability of developing problems with mothers. Antenatal management, what should we look for? So we should be looking for platelet count in FBC, we should be looking for ALT levels in LFTs, we should be looking for urea and creatinine levels in the renal function tests, and then we should be looking for platelet count. If it's not below 100,000, we don't do coagulation screen. Also, we must not forget the presence of the baby. There's a baby there, so we should look for assessment of fetal growth, and that involves clinical examination and ultrasound, and assessment of fetal well-being, which involves ultrasound and CTGs, and antenatal CTGs. In my hospital, we use computerized CTGs. The question comes up, is somebody develops preeclampsia? We know that there's going to be a problem. Why not deliver? So the problems are complications of prematurity, and there's possibility of failed induction needing cesarean section, right? So we can't just deliver everybody who develops preeclampsia. So when to deliver, and this question was answered by a study, and we'll come to that. If there are severe uncontrolled preeclampsia, obviously she needs delivery after stabilization, and attempts to prolong pregnancy are justified in preterm delivery. So question comes up is, if control P, should the pregnancy be prolonged after 36, 37 weeks? And this question was answered by this particular study called the HIPITAT trial. And we should know about this. So it asked the question, induction of labor versus expectant management for mild to moderate preeclampsia after 36 weeks. Should we keep monitoring or should we deliver them? So these were randomized between delivery and conservative management. Severe preeclamptics were excluded because they were delivered anyway. And the results, the composite adverse maternal outcomes are mainly severe hypertension was less common with induction of labor, obviously because they were delivered. Magnesium sulfate was doubled if they were not delivered. So they are more likely to go and develop severe preeclampsia. Fetal outcome was no different, and cesarean section rate was actually lower with induction of labor as compared to conservative management. So the answer is clear. If women develop preeclampsia at term or after 36 weeks or even hypertension, they're better off delivered. The second question to answer is that what about preterm? Term, we've answered the question already, they should be delivered. Preterm, does it make sense? And that question is answered by this study called the Phoenix study. So that asked a question between 34 and 37 weeks, what should we do? Should we keep monitoring or we should be delivering them? So they were again randomized, and the maternal outcome was blood pressure beyond 160 systolic or severe maternal morbidity. Perinatal outcome was composite of neonatal deaths or neonatal unit admission. So about 900 women were randomized. Median gestational age was about 35 weeks of pregnancy, and co-primary outcome was seen in 65% in planned delivery group versus 75% with expectant management group. So we know if you deliver them, then they are less likely to develop severe preeclampsia. But adverse perinatal outcome was seen more often with delivery because it's of prematurity. So there is a balance to have had. If we deliver them, we get less maternal morbidity but more fetal morbidity. So it's a balance to consider. Planned delivery reduces maternal morbidity and severe hypertension compared to expectant management, with more neonatal unit admission related to prematurity, but no indicators of greater neonatal morbidity. Now, it's important to put the study into perspective. The time between randomization and initiation of delivery in days was 1 day when immediate delivery was carried out versus 5 days if conservative management was carried out. So the difference between two was 4 days. So that is what the excess we got. Cesarean section rate was no different. In fact, with conservative management, it was slightly higher cesarean section rate. Eclampsia rate was no different. Hepatic dysfunction rate was no different. Systolic blood pressure, more or less the same. Now, some of you might have seen this fictional BBC drama called Downton Abbey. And here is a picture of Lady Sybil, who tragically lost her life in pregnancy because of preeclampsia. Now, this was set in the years around the World War in 1930, 1940. Tragically, women died then, but women continue to die even now. So it's important to remember that despite all the advances, preeclampsia remains a dangerous disease and women can lose their lives. Thank you so much for giving me a patient here.